Good afternoon and welcome to Lunch with the Investigators, where our faculty will provide their perspective on the current and future management of hepatobiliary cancers. Unfortunately, due to unforeseen circumstances, Dr. Neil Love will not be attending ASCO in person this year. I'm Dr. Kelley, and I have the somewhat daunting honor of standing in as moderator for Dr. Love today. Here are our faculty for today. We're a very multidisciplinary crew. Dr. Arndt Vogel, formerly from Hanover, Germany, now from Toronto, is a hepatologist and oncologist. Dr. Ed Kim from New York is an interventional radiologist, and I am a medical oncologist. Here are relevant conflicts of interest for the faculty as well as research to practice. This program will contain discussion of non-approved uses of agents and regimens. Please refer to official prescribing information for each product. Research to Practice is also hosting a total of 9 live meetings associated with ASCO 2024 this year, and today's program is the first. We hope you'll be able to attend all of the events, either live or virtually, or later as a recorded session. Now, in order to make this meeting more relevant to participants, a survey of 50 general medical oncologists was conducted and questions were provided during that survey that will be asked to the faculty. Dr. Love himself also interviewed about 10 of the survey participants in which they posed cases and queries on a number of key clinical issues that we all face. Video excerpts from these interviews will be featured throughout our program. So, this is where we're headed this morning. We have 3 different modules. We'll start with Dr. Kim, presenting on recent developments in the management of early and intermediate stage hepatocellular carcinoma. Then Module 2 will feature Dr. Vogel discussing first-line therapy for advanced HCC and biliary tract cancers. And lastly, we'll conclude with a discussion of the integration of targeted therapy into the management of advanced biliary tract cancers, which I'll lead. So with that, we'll begin with Module 1 and some recorded cases and questions from community oncologists. Thank you.
Good afternoon, everyone. I'm Neil Love from Research to Practice, this year participating in our ASCO programs virtually, along with 10 community-based general medical oncologists who worked with me over the past few weeks to plan our ASCO meetings and also to contribute some cases and questions for the faculty on the stage. To begin, we address one of the most important recent developments in the management of hepatocellular cancer, the use of systemic therapy in patients in the adjuvant setting and also in patients receiving localized therapy to the liver, specifically TACE, beginning with a case from Dr. Gigi Chen, who has a 49-year-old woman who previously had a stage 3A hepatocellular cancer resected, at which point adjuvant therapy was not administered. 2 years later, she presented with metastatic disease.
She now presents with 2 liver lesions. There's also a small lung lesion that's suspicious for recurrent HCC. She's at a point where she's about to initiate treatment, and so there are actually multiple questions regarding her case. What would be the best approach? Would it be a combination of surgical treatment and systemic treatment? If we do not think that she has a curable disease, then would it be better to do TACE in this setting?
Any questions about combining TACE and systemic therapy a la the Emerald trial?
With interventional radiology, those guys are in rooms, behind suites all the time, and it's not as easy to just have that discussion. I'm curious about how they determine who is a candidate for TACE based on the number of lesions. Because I've had a patient with, say, 7 small lesions, 1 to 2 centimeters, be turned down for TACE. And then I've had patients with 3 larger lesions be felt to be a candidate for TACE. And I'm curious, I know there's this sort of rule of 7 centimeters, but I'm not exactly sure if there's something in their literature that tells them, hey, these are the patients who are going to do well, and these are the patients who are not going to do so well.
So I think this is a great case to start out with. So just to recap, this was a patient who had an initial liver cancer resected in 2022, and then 2 years later recurs with a lesion in the liver as well as a lung metastasis. And so we're provided a little additional information from Dr. Chen here that the patient went on to receive a resection of that lung nodule, which showed that it in fact was a metastatic HCC lesion 2 years later, and also was resected for the recurrence in the liver with another finding of HCC. And the patient is, as we're told, recovering well from surgery, which is good. So maybe we can go to the next slide with the initial questions. And as we do so, I think this is a great case where we talk about the adjuvant question. Before we do, though, I wanted to ask Dr. Kim, when you see a patient like this who has say 2 years later, a recurrence in the lung and the liver, would your first step have been resecting both, or would you have had an IR approach?
You know, that's a good question. I think when they first presented, it was in the early stage and appropriately resected. At that time, if it was 2 or 3 years ago, adjuvant trials were not read out at that point, and we'll go over that in my talk. But in this type of situation, this is technically an advanced HCC because there is extrahepatic spread that was confirmed with the pathology. And so in that situation, we don't really jump to local regional therapy off the bat. We go to systemic because now it has become a systemic process. Let's say there is no disease in the lung or extrahepatic, then I would say that yes, this would be progression to intermediate, and TACE or TARE would be appropriate. But of course, everything starts with a multidisciplinary discussion.
And Arndt, how about you? How would you have approached this case?
Yeah, I think it's a good question. I mean, so this were not the patients that were included into the IMbrave 050 trial, right, as adjuvant treatment after resection of hepatocellular carcinoma. She was like with extrahepatic disease and would with that actually be a candidate for systemic. But on the other hand, I mean, if you have limited extrahepatic disease, you can definitely also think to employ local therapies. So, I mean, in the end, we don't really have good data. It would be tempting to use some kind of adjuvant treatment. And I think it's a longer discussion whether what we think about IMbrave 050, I think it's a positive study. We have seen a benefit. The primary endpoint was achieved, but I think we also all agree that we would like to see more data. Yeah? So at the moment, it's not approved in many countries. So if you can give it outside of a clinical trial, I would understand the approach, but I also would like to see more data from the IMbrave 050 study.
So I think turning to that case where we had limited extrahepatic spread, I would have been tempted to start with systemic therapy. But when we just have one metastasis and a local recurrence like that, I do think those are patients where we do need multidisciplinary consideration. And sometimes there are patients like this that do benefit from either a re-resection or ablation, even a lung metastasis sometimes. So I think this was a great case for multidisciplinary care, and I'm glad she did well. In the adjuvant context now, so this patient, let's say, back in 2022, after the initial large tumor was resected, Arndt, would you, in 2024 now, post IMbrave 050, are there patients that you give adjuvant to, and which ones?
So I definitely would think about it. As I said before, I also think that we need to see more data from the IMbrave 050 study because we do not really know whether we do have an improvement of overall survival and whether we actually cure more patients. And on the other hand, we have toxicity associated with the treatment, which makes it not like a very easy black and white yes or no question. Yeah? So I think at the moment, where we are at the moment with the limited data, we really need to decide on a per patient basis. And if somebody has a really big tumor, maybe even multiple tumor nodules, I think it's definitely tempting to think about adjuvant treatment.
I think for this patient, I would give adjuvant now, that she had a recurrence and a metastasis resected. So in this particular case, I would give adjuvant based on 050 and the unique case. I have been giving adjuvant very rarely, but in, for example, a patient who had multifocal disease and a super high AFP, I recently had a patient with an AFP of 70,000 and 2 poorly differentiated tumors that were resected. And after discussing with the patient what we do and don't know about IMbrave 050, meaning what we don't know, the long-term follow-up data and long-term survival data, but what we do know is that it helps prolong recurrence-free survival in a super high-risk patient. I have used it. I don't yet use it in the average-risk patient. So our next question based in this section is, in patients with intermediate stage HCC for whom we are not considering a transplant, how do we determine when liver-directed or systemic therapy is more appropriate? This kind of gets to the second community oncologist question about when is it too much disease in the liver to treat? And so I'll ask Ed to comment.
Yeah, again, everything is presented in a multidisciplinary fashion, and we have multidisciplinary clinic where actually we see patients side by side with our referring physicians. I would say that it really needs to be discussed in terms of the tumor burden, and for us, a rough cutoff is about 70% or more. We feel that local regional therapy is probably not beneficial. This has also been incorporated into the BCLC. And so in those individuals, systemic or potentially a combination of transarterial therapy and a systemic agent may benefit the patient.
And Arndt, from a hepatology perspective and oncology perspective, are there liver function features or biology features that sway you one way or the other?
Yeah, I would definitely think that it's not only the tumor burden. 90% of our patients have two diseases, the chronic liver disease with underlying liver cirrhosis. So liver function is very important, and we don't really want to harm. And we know that when we apply local or systemic therapies, I mean, this will also affect liver function, and with the decline of liver function, we have a strong impact on survival. And therefore, I think it's really important. And as Kim said, we need to have like the interdisciplinary discussion. And when the radiologist thinks he can do a super selective TACE, yeah, then of course we should really go for it. But if it's not that clear, multiple nodule where you more unspecific with the TACE and where you really may induce some harm to the non-tumor tissue, we would be more hesitant and would start earlier with systemic therapy.
So our last question before Dr. Kim's talk is sort of the lead into one of the topics he's going to talk about. Is in the setting of the recent Emerald trial, which showed prolongation of PFS with using Durva plus Bev after TACE. Are you routinely doing this or reserving it just for specific cases in the absence of follow-up data yet? Go ahead.
I think that it's, again, multidisciplinary discussion. In cases where we feel that there's potentially aggressive tumor biology, in situations where we feel that there may be limited utilization of TACE in the situation, we'll tend to push for the combo therapy.
Maybe you can discuss this now in your talk next.
Oh, all right. Thanks, Katie. So it's an honor to be here with such esteemed faculty at RTP. So I'm going to discuss recent developments in the early and intermediate stage, and we'll start with the early stage on the BCLC staging. This should be really curative therapies that are in play here, good underlying liver function, and usually resection, transplantation, ablation, along with now radioembolization, potentially TACE. I had mentioned this multiple times. It really does take a multidisciplinary team effort because there's also an underlying risk of competing mortality with cirrhosis. And you can see there are a lot of stakeholders that are in this space. In the early stage, very early stage, we're talking about excellent 5-year outcomes, approaching 70% overall survival, and radiation segmentectomy or selective radioembolization has been now incorporated for solitary lesions up to 8 centimeters in size. These are just a list of the liver-directed therapies that interventional radiology offers patients, ablation, Y90, as well as TACE, and some advantages and disadvantages, but I'm not going to go through every detail for the sake of time. I will discuss that the difference between, for instance, a chemoembolization and radioembolization is that chemoembolization main effect is to disrupt the arterial flow to embolize and cause hypoxia, which can upregulate things like VEGF, and that is the mechanism of action of destruction. Radioembolization, on the other hand, is seeding of the tumor bed and not cutting off blood flow with radioactive material because the oxygen will potentiate the radiation and cause tumor destruction. These are recent studies ranging in solitary HCC from anywhere from 1 to 8 centimeters in size that show excellent objective response rates, anywhere from 90 to 100%, with correlating complete response rates from anywhere from about 80 to 98%. So the first study we're going to talk about is the IMbrave 050 that has been presented and published in Lancet in 2023. And this is in individuals who are getting adjuvant therapy with atezolizumab plus bevacizumab who have undergone a curative either resection or ablation. And so you can see the schema here, active surveillance versus adjuvant therapy with atezo-bev. And risk stratification is according to high-risk features. And so what are those high-risk features that we're talking about? Well, they're listed here, three tumors with the largest greater than 5 centimeters, and then 4 tumors, and then less than 3 tumors, but tend to be larger in size. And for ablation, anything between 2 and 5 centimeters in size. And now with that being said, I didn't go over in the previous slide for the sake of time, but really ablation, when you look at the literature, is best achieved for lesions less than 3 centimeters in size for curative. So here they are truly pushing the envelope here as a curative intent treatment, but again, randomizing to surveillance versus atezo-bev. In terms of the primary endpoint, they looked at independent review for recurrence-free survival, and you can see that the curves start to diverge at about the 3-month mark. And the stratified hazards ratio is 0.72, and this was significant for RFS. But as time goes on, you do see the curves start to converge again, and so what had been mentioned earlier in terms of the benefit of overall survival is questioned, and we need longer-term data to really tease that out. In terms of safety and toxicities, no real difference compared to what has been previously published, for instance, in IMbrave 150. And so the adverse event rate profile is quite similar. And so the IMbrave 050, we can say in terms of curative intent treatments with resection or ablation, at the pre-specified interim analysis, the primary endpoint was met and significant with a hazards ratio of 0.72. This is generally consistent across all the clinical subgroups, and the safety profile is in line with what's been published previously. Now, in terms of takeaways from this, we really need to define what we would say is high risk. For me, in our practice, probably more high alpha-fetoprotein, poorly differentiated HCC or infiltrative pattern is probably more consistent. In terms of the BCLC staging for the intermediate stage, conventional chemoembolization has been well established from studies almost 20 years ago. Brivinib study as adjuvant was negative by Kudo, but it established median overall survival for TACE at 26 months. And so I think that needs to be the standard. And since that point, over the last, I would say, 15, 20 years, there have all been negative trials in combination with TACE. Until recently with Emerald 1, durvalumab and TACE with or without bevacizumab, 3-arm study, durvalumab alone or placebo versus the combination of durva-bev. Progression-free survival for the combination of durva-bev and TACE versus placebo was significant and positive according for the progression-free survival, according to BICR for RESIST as well as for MRESIST, of 15 months for the trial arm versus 8.2 months for the placebo arm, according to RESIST. And then, according to modified RESIST, held fairly true of 14.2 months and 8.2 months. Time to progression also demonstrated an advantage of 22 months in the trial arm versus 10 months in the placebo arm. In terms of subgroup analysis, you can see that it held true across multiple subgroups, whether it involved TACE technique, limited portal vein invasion of VP1 or VP2, and then tumor burden at baseline, and this is, I think, a point of controversy, is that whether it's up to 7 criteria or beyond, it shows that it held true in terms of an advantage. Objective response rates, according to RESIST as well as MRESIST, held true about 41 and 43% in the RESIST arm and 51 and 59.7% in the MRESIST. Again, safety summary for Emerald 1, in line with what has been published from systemic therapy trials in the past. Most of the grade 3-4 toxicities were really when it came to the systemic therapy and mostly involving renal adverse events. Here's a list of ongoing combination trials with not only TACE but with TARE. And there are much more numerous trials that are ongoing right now, but these are the largest trials that are ongoing right now. And this is just a summary slide of how people tend to treat according to the BCLC guideline. Very early stage and early stage are going to be very similar with ablation, radiation, segmentectomy, as well as with resection and transplant. And in the intermediate stage, now we have systemic incorporated in there for individuals that we feel are high risk with diffuse or infiltrative extensive bilobar disease. So in conclusion, BCLC-A patients are early stage. We're going for curative treatment, but IMbrave 050 certainly challenges potential adjuvant therapy. BCLC-B, downstaging therapy is important for transplantation, but for those who can't, potential combination with systemic therapy, immune checkpoint inhibitors certainly offers hope in the form of EMERALD-1, which showed a longer progression-free survival with combination versus TACE alone. Thank you.
Thanks so much, Steve. That was a great overview. And in fact, actually prompted a couple questions from the audience that we have time for. So one question from Dr. Steve Lee is, what about Y90 or SBRT actually? Can we extrapolate the EMERALD-1 data to these other modalities yet, or are we obliged to wait for the ongoing trials?
I think in clinical practice, people are probably going to extrapolate some of the EMERALD-1 data into things like TARE. I think SBRT in the intermediate stage may be a little bit difficult because it usually involves numerous targets. But I think that people are going to extrapolate. The scientist in me says that you really can't, because the mechanism of action and how it disrupts the T-cell microenvironment potentially is different. But I think in clinical practice for now, it probably will be extrapolated.
Thanks. And Arndt, what are your thoughts on that? EMERALD and adjuvant or providing additional systemic therapy after Y90 right now in the absence of the data yet?
Yeah, I think we need data, right? I mean, for Y90, it was a little bit difficult road into the clinic, right? I mean, the first trials were negative. Then we learned we need to think about dosing and be more specific and select patients correctly, and not so much the very advanced patients. So I think in our clinical practice, we do see more and more Y90 for sure. And it's, of course, again, I mean, I'm not really sure whether there's any synergistic effect between TACE, Y90, and IO, or whether it's more additive. So if possible, I would treat these patients in clinical trials, and we do have some clinical trials that to get prospective data, or at least to have protocols to really learn more, and not that we are just starting to do things without really good evidence.
We had one other question, which was a question about limited extrahepatic spread to a solitary adrenal metastasis. I think this is where we need multidisciplinary evaluation, and occasionally a solitary extrahepatic site might be eligible for radiation or resection, but I think usually our multidisciplinary team will recommend a tincture of thyme and usually systemic therapy first, and then reevaluate to make sure there's no other sites of disease over a period of time. Now, it's time to move on to Module 2, which is first-line therapy for advanced HCC and biliary tract cancers.
The selection of first-line systemic therapy for patients with advanced HCC was made more complicated with the introduction of the STRIDE regimen of durvalumab and tremelimumab. Our oncologists have many questions about how you make this decision in your clinical practice.
Something that I struggle with, is there a benefit of one regimen over another? And how we determine which regimen may be better for individual patient? Is there any data to suggest that one regimen may be better based on the etiology of the underlying liver disease or HCC? Do they get a sense that the STRIDE regimen is effective for proportion of patients where there's prolonged survival? Is there any data to tease out which of those patients who are more likely to benefit from dual checkpoint inhibitor therapy? I think a common scenario is in real-world community practice, we often have patients who have compromised liver function who may still have good performance status. Do investigators still treat these patients if they have Child-Pugh B liver disease, if they have otherwise reasonable performance status? I think it's particularly important in patients whose liver function is compromised by the underlying tumor itself.
If you have a hepatologist telling you, hey, this patient with their total bilirubin of 7.5, but it's been stable, this is a patient who's in a different situation than the patient whose bilirubin was 1.5 2 weeks ago, and now it's 7.5.
There may be some preference for atezo-bev over durva-tremi, but then there's also the Child-Pugh score that is more lenient with durva-tremi. Bevacizumab and the EGD for varices is one aspect that gets talked about a lot. I'm okay in those comparisons, but it's always nice to have that spoken about just to make sure that there aren't any remaining knowledge gaps.
I don't think all varices are necessarily created equal. In treated varices, can you give bevacizumab? How much of a contraindication is that? Or would just people switch over to dual immunotherapies in those situations?
So that's a lot of questions in a rapid pace fire there. But I think the first one that Dr. Brenner mentioned that's not quite to this question yet, but is etiology a factor in choice? And I would answer on the medical oncology side and say right now the data we have suggests that the response rate and PFS are quite similar, whether someone has Hep B, Hep C, or non-viral. And the meta-analysis data that we've all heard about that suggests potentially worse outcomes for non-viral are actually driven more by post-progression events and comorbidity, maybe access to therapy. So there isn't a great reason to choose based on etiology at this time from what we know. I'll ask Arndt, would you agree, as a hepatologist as
100%.
well? So to put that to rest, right now we don't think there's a reason to choose based on etiology, but we do choose based on toxicity risk. So patients with portal hypertension, significant vascular disease, or other contraindications to BEV may be better for a dual immune checkpoint inhibitor regimen, and, but otherwise patients who have no contraindications to bevacizumab would be a good candidate for atezo-bev. So that addresses the questions that Dr. Brenner posed. And then this question we see here, I'll direct to Arndt in a minute, is let's say a patient now received atezo-bev in the adjuvant setting or with TACE, durva-bev, and the per EMERALD-1, and then has recurrence. What would be our strategy for first-line therapy later if there is further progression or recurrence?
Yes, I think this is one of the important questions we need to ask now, right? When we use these ICE-based therapies in earlier settings, what is the impact of later line treatment? And we don't have these data. Yeah, we know that maybe in the future we need to think about anti-drug-induced antibodies, for example. We know that in up to 30% of patients treated with atezolizumab, these ADAs can develop. We don't really know what is the impact. It's maybe an academic discussion at this point. But we have some retrospective data suggesting that high ADAs also correlate to worse outcome and less efficacy. So far it's not really a problem. We don't really know, but something we need to consider. And whether we can use IO beyond progression, I mean, it's investigated in a couple of trials. We will actually see one trial here at ASCO with regorafenib and pembrolizumab in patients that have been pre-treated with checkpoint inhibitors in the first-line setting. So this will give us, I think, a little bit of an answer, whether this is what we can expect at least. We have IMbrave 251, a large phase 3 study, which also looks at the benefit of treatment of atezolizumab beyond progression. So we will get data very soon to address these questions about and I think we can probably extrapolate these data also to the question you just posed here. What should we do when patients have received IO-based therapies in earlier settings?
And I think I would add that for somebody who had atezo-bev adjuvant and then recurred, say, a year later, I would probably go with the STRIDE regimen because we do have some case series suggesting benefit from adding a CTLA-4 inhibitor to IO in melanoma, lung cancer, other tumor types, and in HCC as well now. So that's probably what I would do for a patient like this if they recurred a window of time later. But as Arndt says, we have more data to come. So next question, what about a Child-Pugh B7 cirrhotic patient? And I think, again, one of the community faculty had the astute point that these are a heterogeneous group and not all B7s are the same. Some are acutely decompensating, and a week ago they were A5, and some are B7, B8 for the past 3 years, and those are very different flavor of patients. I think I would say, for me, the biggest issue is portal hypertension and bleeding risk with BEV. So making sure that these patients absolutely need an endoscopy, absolutely need variceal assessment. If there are high-risk varices or history of variceal bleeding, that's a predictor for future variceal bleeding. So that would steer me towards STRIDE data, the STRIDE regimen. We don't have prospective data for either of those trials, atezo-bev or STRIDE in Child-Pugh B yet, though there are trials ongoing. So I think this is a patient population where we can use either regimen if we've done really careful endoscopy and portal hypertension screening. Aren't any other additions?
So maybe one point, I mean, I completely agree with the bleeding risk, and you definitely need to do an endoscopy in patients with portal hypertension when you use BEV. Yeah? So I mean, it's so critical, and we have seen so many bleeding events if you don't do it. So you need to do an endoscopy. But the other point is it's not only bleeding, right? So if you have patients with advanced liver cirrhosis, you have other forms of decompensation, ascites, encephalopathy. Yeah, so I think it's the bigger picture and also how liver function develops. And I think for atezo-bev, it's an aggressive treatment, right? So it also has some toxicity. And I think what we have seen in real-world data sets that the outcome is not as good as we have seen it in IMbrave 150 in patients with more advanced liver disease. So I think I mean, we need data. We have the CheckMate 040 study for Nivo alone. I think just a checkpoint inhibitor is definitely something you can consider. And whether you add BEV or TREMI, it really depends on the patient, and it's not only bleeding, but also other forms of decompensation.
Great point. We have one more community oncologist input.
As in a number of solid tumors, the first-line therapy of metastatic biliary tract cancers now includes the addition of a checkpoint inhibitor, first durvalumab, more recently data with pembrolizumab. But in addition to choosing the chemotherapy regimen and IO, another important consideration where we heard a number of questions from the oncologists was the issue of the use of immunotherapy in patients with prior autoimmune conditions.
73-year-old gentleman, he was started on chemotherapy with platinum gemcitabine, which he tolerated quite well, has very active Crohn's disease, which we're actively treating right now, which is a little stressful. He's on one of the new novel agents. The question would be, in a patient who does not have extensive autoimmune, is utilization of IO now a standard of care in the setting of people who have concomitant malignancies and autoimmune diseases, which is extremely common in practice. And because none of the clinical trials probably looked at these patients, every day we're faced with these conundrums of who to treat with active autoimmune diseases and who we can't treat.
So we have just a minute before the next presentation from Arndt, but first question, for patients with advanced biliary tract cancers, when do we not use Durva or Pembro? I think exactly in the case described, somebody who has very active autoimmune disease, there's a very high risk of flare, and you need to do that in concert with the rheumatologist or gastroenterologist if it's Crohn's, and potentially avoid it if it's a person who's high risk, because there is a very high risk rate of flare that can be serious. Transplant patients, patients who've had a prior liver transplant are another contraindication to adding Durva or Pembro in this context. And then the last one, I'll direct to Arndt. What do you use as your first-line biliary regimen in patients with actionable FGFR?
So maybe coming to the first one again briefly, because just this morning there was a paper in European Journal of Cancer, and I just tweeted about it. The question is, what is the risk of flares if you treat patients with autoimmune diseases with checkpoint inhibitors? And it was actually over 20,000 patients looked at, and 36% developed flares of the autoimmune disease, and 3/4 of them, 72%, required steroid, but mortality was extremely low, below 0.1%. So I think it's feasible, but there's definitely a risk of both flares and de novo immune-related adverse events. Yeah, but it's an interesting paper just published today. So, okay, and regarding FGFR alteration, so what first-line regimen would you employ? So I think we don't have any data. We have some data from the TOPAZ study, which looked at the outcome according to underlying genetic alterations, and there were really hardly any subgroup that benefited more or less. If at all, patients with BRCA mutations tended to do a little bit better, and there was also a slight enrichment of patients with IDH1 mutation in the long-term survivors. And for FGFR alterations, we have not seen any data that they would do better or worse. So I think I would treat them as on other patients as well.
So right now I do the same with treat the standard GemCis plus either Pembro or Durva as a standard first line and reserve the target therapy in second line for now. So Arndt.
Okay, so going to first-line treatment, this is the ESMO guideline. We are just in the process of updating the guideline because we have seen so many advances in recent years, and there's more to come. I mean, we will, and I will get back to this, get data from the CheckMate study in HCC. But what we have also emphasized already in the last update is that, first of all, we do have several options for patients with advanced disease. We can treat our patients sequentially, and having so many options, these systemic therapies are moving to earlier settings. I mean, they're clearly already established in intermediate stage, and as we have discussed in the beginning, we need to decide who gets local, who gets systemic, and maybe who gets a combination of both. But we do have options, and we can treat our patients sequentially. So how should we treat our patients? And there were already some very good questions we heard before. I mean, which regimen would be preferred for a specific patient? The first positive trial was the IMREV 150 study. You all know the study, combination of atezolizumab and bevacizumab. There was clearly an improvement of all efficacy endpoints. It was clearly recommended as standard of care in the first-line setting at the time when the study was published. We have seen validation data, if you like, from the Orient 3-2 study, a study that mainly recruited in China but has very similar efficacy data, so a very consistent picture. And we have also some, I would almost say, additional validation for this concept of the combination of a checkpoint inhibitor and then VEGF-directed therapy. In this case, it's not an antibody as bevacizumab, but a tyrosine kinase inhibitor, rivoceranib. The CARIS 310 study was mainly recruited in China. Only 17% of the patients were recruited were Caucasian patients. But I think the efficacy data are very interesting. It's actually the longest survival we have so far seen in a phase 3 study with more than 22 months. The control arm performed very good in the study. Sorafenib median overall survival 15 months. So all efficacy endpoints similar to the IMRAV study were improved. One point that is very often mentioned when we think about this regimen is the toxicity, and there's definitely toxicity associated. There were also a couple of patients that in which treatment was stopped due to toxicity. But I think it's important to look here very closely what kind of toxicity do these patients develop. It's mainly hypertension, increase of liver enzymes, and proteinuria, which I think are in line with the mechanism of action of the drugs that have been employed, and overall the quality of life of the patients was not impaired or was not worsened compared to sorafenib. Of course, we would like to see treatments that are better tolerated as sorafenib, so this is definitely not an advantage. But I think on the other hand, you need to see the efficacy data. There will be an update of the CARIS study at this ASCO with more long-term follow-up, and you will see that also the overall survival improved compared to the initial studies. So I think in terms of efficacy, it's definitely an interesting regimen. It has toxicity and it's not yet approved, so we will need to wait and see whether and how this is basically approved by the regulatory agencies. The other combination we are discussing are the two checkpoint inhibitors. The first study, which paved the way a little bit, the CheckMate 040 study, looked at nivo-ipi, different dose regimens, but very interesting survival data. The CheckMate 9DW study has been initiated. We are waiting for this study for quite a long time, and finally it is here. So it will be presented by Professor Galler on Tuesday, and we will see how this combination compares to STRIDE, the regimen we have learned a lot about from the Himalaya study, and we have seen a press release that the study is positive, so that I think is good news, and obviously we will get another regimen in the first-line setting very soon. This is what we have for dual checkpoint inhibition, and I think it's a very interesting update here from the Himalaya study. You can see 4-year updated survival data, and this is really changing. I mean, in the time when we only had sorafenib available, we were only talking about a median overall survival of less than 1 year, and now we are looking here at 5 years survival data. So that's definitely an improvement. It's not only in the experimental arm, as you can see, which did better compared to sorafenib, but also in the sorafenib arm, we do see more patients with long-term survival. And I think this is important when we think about these TKIs, the outcome we see today when we have sequential therapy available compared to what we have seen in the pivotal studies when there was really no second-line treatment available. And specifically for sorafenib, we have seen in a couple of trials longer survival than in the pivotal SHARP study. Also, looking at response is important. This was a very interesting analysis indicating that disease control is really important, and specifically when we achieve a disease control with checkpoint inhibitors, we do see long-term survival benefit. You can see the curves are really separating very nicely compared to sorafenib. So the response to a checkpoint inhibitor is somewhat different from a response to a tyrosine kinase inhibitor. Not everything has worked, and one of the negative study, which I would like to highlight nevertheless, is the LEAP-002 study, where pembrolizumab and lenvatinib were combined. This was, I mean, when you just look at the p-value, you would think it could be a positive study, but there were a lot of interim analyses, alpha splitting, so in the end, the positive study was a negative study, despite a very interesting survival of more than 21 months. which was for quite a while the longest survival we have seen in this setting. But here again, the control arm outperformed. Lenvatinib had a median overall survival of 19 months, clearly better than the 13 months we have seen in the REFLECT study a couple of years ago. So again, highlighting that having more options and being able to treat patients sequentially has an impact on overall survival of our patients. And I highlight this study because, as it has been shown before, this combination of lenvatinib plus a checkpoint inhibitor is investigated also in earlier settings, and maybe at some point we will see this regimen coming to the clinic. So far, no positive study, unfortunately, but I think it's an active treatment. So this is where we are today. We do have a lot of options available. There will be another combination probably on Tuesday, and then we have 5 ICE-based combinations or monotherapies, tislelizumab, durvalumab, 2 monotherapies with at least non-inferior survival compared to sorafenib. Coming back to the child-PUB question, maybe even if these patients have not been investigated in the clinical trials, and we have the 2 TKIs, and lenvatinib and sorafenib, which can be used for patients that do not tolerate checkpoint inhibitors. And similar to HCC, we have also made a lot of progress in BTC here, not so much with the immunotherapy, but we do have 2 positive trials, TOPAZ and Keynote 966, but we also have all these targeted therapies which are mentioned here and which really make NGS testing in these patients mandatory, and they are really up to 50% of patients have druggable alterations. So NGS testing is really highly important. Immunotherapy has also found its place in BTC. These are the updated data from TOPAZ. Also here you can see now long-term survival data, and clearly with the addition of immunotherapy, we do see this tail of the curve effect and more patients with really long-term survival. In terms of side effects, we do not add much toxicity. Of course, there are these immune-related side effects, and we have discussed this before, but overall tolerability is really good. Again, here, response is important, and specifically in the responders, we do see a clearer separation of the curves, which occurs quite late, interestingly, but both for patients with stable disease and with partial and complete responses, we do see nice separations of the curve when we add a checkpoint inhibitor. And similar data has been published actually by Keynote 966 for pembrolizumab. Similar efficacy, good validation of this concept of GemCis plus a checkpoint inhibitor.
Perfect. Thank you, Arndt. There are a couple more slides that folks can see in their online package, but we need to move to Module 3. So that was excellent. Thank you for this great summary, Arndt.
We've been kind of joking around the last few years that biliary tract cancer is starting to become the new non-small cell lung cancer, at least in terms of targeted therapy. Our oncologists are very interested in your thoughts about this treatment modality in biliary tract cancer, beginning with FGFR2 alteration and the use of a number of FGFR inhibitors to manage this disease.
She initially presented with large liver masses. She also had ascites, and we did a biopsy of the liver lesion, and that was compatible with cholangiocarcinoma, which did show FGFR fusion present. She also initially did have hyperbilirubinemia, so she did have a stent placement, and that had improved her bilirubin level. So for her, we were able to, use cisplatin, gemcitabine, durvalumab as a first-line therapy. But one of my questions is that there are some patients, even with stents, who are not able to get their bilirubin into a closer to normal range. So what will be the best first-line therapy in that setting? Would you use FOLFOX instead? Is there a role of adding IO to the FOLFOX treatment in that first-line setting? In this patient's case, about 8 months into the durvalumab maintenance, she had disease progression in her liver. So we started her on FGFR inhibitor. She actually just started this very recently, so I don't have that first imaging after she started it yet. So waiting to see how she responds to it. She's tolerating well. She really has not had a lot of side effects from the medication. I would like to, get the faculty's advice in terms of how they choose the different FGFR inhibitors in this population of patients.
So Gigi also brought up a lot of questions that are germane in biliary tract cancer. So the first she mentioned is somebody whose bilirubin isn't coming down despite stents, and which chemo do you use? I generally do use FOLFOX in those patients because of its lack of hepatic metabolism. I have not been combining with immunotherapy since we really don't have data for doing that in biliary tract cancer. Ed, what do you think about someone who's not stentable endoscopically? Do you see those patients for percutaneous drains?
Yeah, absolutely. I mean, we are able to percutaneously place a biliary drain to try and drop the bilirubin in those individuals, so that's not an issue.
So if there's a good target, sometimes a drain can help, not always, but...
Not always. I mean, if there's isolated ducts, multiple ducts, then we're not going to place multiple biliary drains. But if there is isolated, let's say the whole right system or left system is occluded, then we can place a stent for sure.
And then Arndt, to the question about pemigatinib versus futibatinib in a second-line patient, say with an FGFR fusion or rearrangement, in the setting of elevated bilirubin or in general, do you have an algorithm for which to choose? Or
So how much time do we have?
2 minutes, 2 seconds.
2 seconds, okay. I think it's really difficult. And so I think both have similar efficacy, very high disease control rate, good response rate. I think it's hard. We don't have any biomarker to suggest that we should use pemigatinib or futibatinib. The only thing to consider is that we do develop on-target resistance mutations with pemigatinib, which could allow us to use futibatinib as a second FGFR inhibitor in the kind of second-line setting. So this opportunity of sequentially use FGFR inhibitors, I think is personally very, very interesting. When you look at the efficacy data, you could argue there's a slight advantage for futibatinib. So in the end, I think we need to use them in clinical practice, and both are very valid options, and no matter what, one of them should be used for patients with FGFR2 fusions.
Great. In terms of the most common toxicities, I'll cover this in the talk, but we worry about eye, mouth, hand, foot, nail loss is very common, hair loss, and for the pan-FGFR inhibitors like futibatinib and pemigatinib, hyperphosphatemia. Almost everybody, greater than 70% in most studies, will require a phos binder like sevelamer over a prolonged period of time to keep their phos down and reduce the risk of ectopic calcification. In terms of the detriment to quality of life, I would say mouth, hand, feet, and nails are the most day-to-day bothersome side effects because they can interfere with eating. People really do lose their nails entirely and get sort of a paronychia onycholysis phase where they're very uncomfortable. So nail care and reassuring patients that once they fall off, they actually feel better is a really important part of supporting patients through FGFR inhibitors, especially the month 3 through 7 range. And then after that, they actually improve. So next faculty question.
The not unexpected but yet somehow shocking pan-tumor approval of TDXD recently in all patients with IHC3+ solid tumors now means that every part of medical oncology now must address this important agent and HER2-positive disease in general. And as you would imagine, there are many, many questions that docs in practice have about this exciting modality, which also has some significant clinical concerns in terms of toxicity.
We know there's an emerging paradigm in biliary cancers with targeted therapies. I think one of the important ones is HER2. We also know that TDXD recently received pan-tumor approval. Where did investigators use this agent in patients with biliary cancers? Would they consider using this agent in the front line or another HER2-directed therapy in the frontline setting? I recently had a patient who was in her late 80s with a metastatic gallbladder cancer who was not a candidate for chemotherapy but was HER2 positive. Would the clinical investigators use a HER2-directed therapy in the frontline setting, and would they prefer a treatment such as TDXD, or would they use pertuzumab and trastuzumab in combination? And is there any data to support one over the other?
So Arndt, how about the first one?
Okay, I mean, that's very interesting, and HER2 is definitely a very interesting target. I mean, we do have a lot of options here. We have not only trastuzumab, pertuzumab, trastuzumab deruxtecan, tucatinib, trastuzumab, zanidatamab. So we have so many options. We don't have any head-to-head comparison, so it's hard to tell which one would be the preferred one. I personally think that similar to gastric cancer, that combinations with IO chemotherapy could move into, with and without chemotherapy, could move into the frontline setting. I think there will be some studies. Jazz Pharma, for example, with Zanidatamab will initiate such a study very soon. At the moment, we do have good data for the use of these drugs in the second-line setting. For trastuzumab deruxtecan, maybe the important point here is also to say that we do not only have amplification, which goes most often hand in hand with overexpression, right, by immunohistochemistry. So how should we best detect it? But we also have mutations, right? So we have HER2 mutations, and there was just a couple of days ago in Lancet Oncology the pan-tumor study for trastuzumab deruxtecan, highlighting that this drug also has efficacy in patients with activating HER2 mutations. So I think trastuzumab deruxtecan is really an interesting option. Again, similar as before, sequential treatment starting with trastuzumab, pertuzumab, or tucatinib, and then switching to trastuzumab deruxtecan with the chemo component. I think it's also an interesting food for thought. So here are definitely options, and all patients should be tested for HER2 expression.
And I would underscore what you just said, HER2 expression, because in an NGS panel, they don't always call low-level amplification. The tests may not report back as a low-level amplification. So if you have a high-level amplification, you're done. But a low-level amplification, or without knowing for sure, I also send for IHC.
Yeah.
So we'll cover zanidatamab in my talk coming up, so I'll skip to the last community faculty comments first.
Our last query involves a very interesting pathologic situation brought up by Dr. Rupard, and one where we've seen a number of cases presented to us by general medical oncologists asking what kind of basic approach to take in these patients.
Recently, I had a case of a 67-year-old man with an unresectable cholangiocarcinoma and high AFP. And the interesting thing about him was that the pathologist told me that there was a component of hepatocellular carcinoma in there as well, that there was potentially some crossover. And I'm interested to hear whether your faculty members are treating those primarily as hepatocellular, in other words, more geared towards immuno or even maybe a CTLA-4, or are they aiming the treatment, with chemotherapy more toward the biliary component?
So I can share what I do to start, and then we'll see how it resonates with Arndt. But generally, if it's a mixed HCC cholangio, I'll treat with a regimen like Gemcis Pembro or Gemcis Durva, because that will cover all of the components, because we know that checkpoint inhibitors have activity in HCC as well. At progression, I will often get another biopsy to see, does the tumor look more, is the progressing component of cancer more like an HCC or more like a cholangio, and then tailor second-line therapy accordingly, and make sure to get next-generation sequencing, because these patients might have a target, because we don't really understand quite how mixed HCC cholangiomas are driven. So that's my approach.
Nothing to add.
All right.
So, I think I agree. So it's the question, do you start with Gemcis Durva, which makes a lot of sense, or Atezo-Bev, and I agree with Gemcis Durva or checkpoint inhibitors. You do cover both, right? And I completely agree, testing is important. We have seen a couple of patients with FGFR2 fusions, actually, so sequencing is definitely important.
Great. All right, with that, we'll go to the third talk, and I'll try to be quick here so we have time for any questions at the end. So integrating targeted therapy into management of advanced biliary cancers. I'm going to focus mostly on areas of FGFR2 and HER2, because there's been a lot of activity. And this is just a quick alphabet soup slide to remind us that intrahepatic cholangiocarcinoma is distinct from extrahepatic. Extrahepatic is comprised of perihilar or Klatskin tumors. Distal is that part of the bile ducts that reach the duodenum. And our acronyms include advanced biliary cancers, or ABC, as well as BTC, which we'll use throughout. And another reminder slide is what's our current status of second-line therapy. Right now, we're using targeted therapies predominantly in the second line, as we don't have first-line data. And that's really because second line is a very poor prognosis area where we have FOLFOX data, but as you can see here, the median survival is only around 6 months with FOLFOX, median progression-free survival 4 months, and the response rate only 5%. So that's our comparator for contemporary chemo options. So back to the anatomy of biliary tract cancers, the targets vary somewhat based on the location of tumor, where we see some of our their actionable targets more enriched in intrahepatic, like FGFR2 and IDH1 or 2, which are almost never seen in distal or perihilar or gallbladder. Whereas EGFR and HER2 mutations and overexpression are more common in gallbladder, though also can happen in intrahepatic. And then there's some that are seen throughout, including a low rate of MSI high, around 1 to 3%, BRAF around 1 to 5%, that's pretty symmetric across the different areas, and aren't alluded to HER2 or ERBB2 mutations, which can happen in any location as far as we know. And then rare likelihood of NTRK, RET, and others, but worth checking for. So starting with FGFR2 fusions, these are present in about 10% of intrahepatic and not so much in any other location. They produce a chimerically constitutively active FGFR2 kinase and can be inhibited by a variety of different inhibitors, the ATP-competitive pan-FGFR inhibitors that we know of with pemigatinib, for example, the non-ATP-competitive covalent inhibitors like futibatinib, and some selective FGFR2 inhibitors in trials like RLY-4008. So starting with the pan-FGFR ATP competitive inhibitors, these have been predominantly studied and approved in the second line, and these include pemigatinib, that we talked about earlier, with the efficacy data shown here from the FIGHT-02 trial with a 35% response rate, prolonged duration of response. And then infigratinib was approved, but has been since been withdrawn from manufacturing due to the competitive landscape. Class toxicities we talked about: hyperphosphatemia, stomatitis, eye toxicity, hand-foot syndrome, nail loss. Here's some additional data drilling down on pemigatinib. We can see response rate again was 37% overall. Interestingly, cohort B were patients with other FGFR alterations, not fusion or rearrangements, but mutations, and we see a 0% response rate in this small cohort. And cohort C was patients that were wild type for FGFR2, and we see also that this drug didn't have activity. So very useful data just to know that the activity of pemigatinib is predominantly in fusion rearrangement, not so much activating mutations, at least in this small cohort. Now, the problem with ATP-competitive FGFR2 inhibitors and also non-competitive are the development of acquired resistance mutations in the kinase domain of FGFR that occur in various places and can be polyclonal, so different tumors can have multiple resistance mutations. And here we go. Fortunately, some of the next generation FGFR2 inhibitors, including the RLY-4008 and futibatinib itself, bind in a different way and can be active against some of the common resistance mutations. There are a host of next-generation trials on the horizon that hopefully will help in this acquired resistance setting. So here's data from futibatinib. We can see the response rate was 43%, and it was also very prolonged and durable, and most patients did get some degree of tumor regression. And this led to FDA approval as well in 2022. Question about what about other FGFR2 alterations beyond fusion or rearrangements? And I mentioned earlier, pemigatinib really is restricted to fusions or rearrangements. Futibatinib, shown in these dark green bars, does have responses in some mutations, FGFR2 mutations, and in resistance mutations, so can be used in a selection of these in after pemi progression. There are several intriguing drugs on the horizon. One of them is RLY-4008, which is a selective FGFR2 inhibitor and has a very high rate of response in FGFR inhibitor naive, and also hits some of the resistance mutations. Another drug presented at ACR as well as GI ASCO this year is tiningatinib, which also shows activity in these little yellow boxes against some mutations, either primary mutations or acquired resistance mutations, so another drug to keep an eye on. Now, turning to HER2 overexpression or amplifications, this is a nice summary slide from my friend and expert colleague, Dr. Lipika Goyal at Stanford, showing just a selection of what's available now. We have trastuzumab plus pertuzumab from the MyPathway trial in either HER2 3+ or amplified, and the response rate was 23%. Zanidatamab, I'll show on the next slide from the Horizon trial, which showed a response rate of 41%. Trastuzumab tucatinib presented at ASCO last year in 2023 in either amplified or HER2 3+, shown here. Another high response rate, 46%. And then lastly, which we'll come to as well, trastuzumab deruxtecan in the Destiny pan tumor trial leading to recent approval, which I'll show on another slide. So specifically, zanidatamab is a very interesting new agent with a bispecific mechanism of action, targets the dimerization domain as well as the juxtamembrane domain of HER2 and leads to down-regulation of HER2. And in the Horizon trial presented at last ASCO, it showed a really nice response rate in the HER2 3 plus by IHC of 51%, not so much in the 2 plus or IHC low, 5.6 or 0% respectively. It does have toxicity, including diarrhea, that was generally manageable with supportive care and infusion reactions. And we can look forward to future trials of this agent in BTC, given this really intriguing activity in the 3 plus in particular. Here's, again, another slide with more efficacy data, again, showing the 41% response rate that was generally similar across key subgroups, except the HER2 2+ group, which did not show as much benefit. This is in the second-line setting. Safety data, again, is reassuring, with diarrhea being a predominant event. Rates of rejection fraction reduction on echo is pretty low. 3% were grade 3. Now, turning to the other HER2 agent that we've been excited about based on its recent FDA approval, trastuzumab deruxtecan. It's been studied in 2 different biliary tract cohorts in the HERB trial. 32 patients with either HER2 high, defined as 3 plus or 2 plus amplification or positive-ish, had a response rate of 36.4% in that setting, or a response rate of 12.5% in the HER2 low population. But of note, this agent does confer a risk of ILD in around 25% in the HERB trial. And then more recently, the Destiny Pan-Tumor02 trial included a biliary tract cohort in 41 patients, shown here in the purple. And in the waterfall plot, you can see here in the purple as well, and showed, again, a really intriguing signal of activity in the 3 plus patients with a response rate of 56%. Still the concern of ILD that requires very close monitoring. 10% in this population got ILD. So based on these data, the FDA granted a tumor-agnostic accelerated approval for TDXD in patients with HER2-positive tumors, HER2 3+ tumors. These PFS and OS curves also show the distinction and benefit in the 3+, with the 3+ being the blue curves in both sides, less benefit in the 2+ or low. Toxicity, again, the key points to note are the ILD, and that was about 10% in the TDXD study. So final summary, IDH1 mutations, that we have ivosidenib, which has a full FDA approval. FGFR2 rearrangement fusions, we have pemigatinib and futibatinib with accelerated FDA approvals, and other new agents on Horizon that target acquired resistance. And then a host of options for tumor-agnostic settings with these particular mutations shown here. These target therapies have substantially improved outcomes for patients and options for treatment. And tumor profiling with NGS and now HER2 IHC are a standard of care. And so just a reminder that all of our patients with advanced BTC should have comprehensive molecular profiling in a panel that includes the intronic region of FGFR2. Not all panels do, so check for that, because FGFR2 fusions occur in non-coding intronic areas. And again, as I mentioned earlier, we want to make sure that we're not missing low-level amplification, so HER2 IHC should also be checked to complement the NGS data if not amplified on a panel. And with that, that brings us to the conclusion of our program, and I want to remind you of the multiple other programs ahead for Research to Practice this ASCO, and thank you all for your attention.